Good afternoon, everyone. Let us not delay ourselves. Please join in. I am ready to present already. Let me introduce the next presenter, Yulia Tereshkovich, our occupational therapist. I may say the main occupational therapist of the facility. Please listen. She's smart, cool, and creative. To your attention. Thank you. Okay, let us start. Who occupational therapist? I'll mention shortly. Specialists in the healthcare who deal with independence of the patient and work on improving their life quality. Thank you. Adaptation. Let me start my presentation from studies. Based on this data, patients with spinal cord injuries prefer intermittent catheterization rather than constant 50%. 47.9 from this group say that intermittent cathing improved their quality life. So the objective of ergotherapy is improving functional problems, resolving functional problems of the patient. We're going to work together with the physical therapist. We will teach how to manage clothes. We will approach as a team to fulfill objective. We'll help with placing genitals of the patient with tetraplegia, with keeping catheter. Also, we keep with a purity of procedure. We will develop, if necessary, adaptive methods, and will help take care for incontinence. Positioning. I will not do without physical therapist here, because physical therapist's role is mobility of patient. If initially easier to choose position in functional bed, possible to bring up the upper edge, making patient reach their genitals. In the process of working with patients, we need their mobility, their balance, and their skills in wheelchair, because the catheterization may be made in functional bed, in usual bed, in a wheelchair, even in the toilet. Managing clothes. If a patient will not be able to take off and to put on hoses, we may help him adapt. I mean, in different velcros or adaptive hooks that will help to open naked genitals and to move during intermittent catheterizations. And different clothes that may be big skirts, elastic belts, hoses zipped from sides also may be useful. Button from sides. A couple of words about team approach. I'm very happy that I work in a team. First of all, I'm thankful that people believe in me, that they give me opportunity to show myself, and what this team approach is going to be based on. Objective of the patient to teach management is a teamwork. I will break down a little physical, dealing again with patients' ability. Physical rehabilitation doctor will help avoid further problems or helps with the urology area. Nurse will help to do control, to supervise the procedure. There's also representative of rehabilitation team, first contact instructor. This person will help to have conversation with patient, to tell his her example, to share the experience working as a team, possible to efficiently achieve goal. fulfillment. We quite often I posted those images from personal sources. Pretty often we may get together to discuss issues or instead successes, sharing experience. Uh, Location of genitals. For that, occupational therapist might need a material called thermoplastic, and from this material we may produce additional adaptations. For male, for instance, when they have worse hand functionality, it might be difficult for them to place a penis. So the example how to keep it in place for ladies, this is a mirror that will help even seated provide um, catheterization procedure, keeping catheter. If there are difficulties again with hand functionality, here thermoplastic again comes to help. From this material again, one more type holders for catheter that help also to gain reassuredness in performing cathing procedure for patient, or at least just to start to improve in this later. Keeping hygiene. So this is very important. You could notice that in the territorial hospital we have many pets, and often patients like play with them, and then they may do accidental intermittent catheterization. It shouldn't be like that. I had such a patient in my practice. We definitely underline for patient importance of personal hygiene, washing hand, using one disposable diapers and wet napkins, and involve a nurse. Involve, what do I mean? If you help patient with the functional problems, we hand it over to the nurse. The way the patient performing, how we teach the patient, how he's coping or she with her clothes, so that she may control only the procedure. Several examples of adaptation for a patient. I will tell briefly. Backpack is irreplaceable assistant. You may place all the incontinence uh, things inside to visit public places and to use it as storage for all the necessary things. Booklets. Example for the beginners, how to do the technique of the procedure, the fastening. Not only we're going to speak about intermittent catheterization, for instance, for constant catheterization, then we recommend how we may attach bags to collect urine, how they may be released from those urine, um, voiding and taking care of them, uh, opening ropes if the wrist function is dysfunctional. It helps. Mini toilet that one may also take on the go. It fits both for male and female. One of the options how to attach a catheter. This is a way of using, and to avoid difficult situations during classes. We may even use resin. Taking care for catheterization, we may work both for intermittent catheterizations, improving management, or for instance, if patients got constant catheter, then we recommend attaching something to void urine toilet, or even the bottle, for instance. I like this option a lot that we also recommend to patients. For instance, sewing on pockets on the cots that they may keep all the objects for incontinence, or to make a bag near knee to adapt the clothes so that it can be drained without additional assistance. This is also a way to attach. That person may drain the bag, opening the valve by him or herself. That's it. Thank you for your attention. If you have questions, please.
Thank you for this presentation, very interesting, and you have a very big experience, but can you share with us what is the level of patient who was capable to caesarize himself? Mm, it's important what is in the theory, but what was in your practice? Thanks for your question. So in my practice, it was a C6. Um, so I put it here. So it was one of our first patients with whom we could do this procedure with adaptive tool, and so we communicate with this patient, and now he uses the tinnitus clipper. Thank you for listening, and have a nice day to all. The next lecture is the presentation by our friend and colleague, Professor Andrei Krasikov, neurostimulators of the bladder, principles of operation, technical aspects, and effectiveness. So, Mr. Professor, we are waiting for you.
Virtually from Vancouver, Canada, during this wonderful and crucial conference about management of urinary bladder dysfunctions in people with spinal injury in Ukraine. I'm a professor of physical medicine rehabilitation, and big part of my clinical practice, I do spend talking with my patients about how to manage urinary bladder dysfunctions. And today specifically, I would like to focus in a short period of time to describe you potentials for the neuromodulation of urinary bladder function, specifically following spinal injury. First, I will discuss with you innervation of urinary bladder and function of urinary bladder in a normal patients without any neurological deficits. I also will discuss concept of management that we presently have to start management of upper urinary tract dysfunctions in people with spinal cord injury. And then I will discuss very briefly evidence for use of neuromodulation in management of neurogenic blood in people with spinal cord injury. Urinary bladder functions are crucial for our functioning, and we know how it's important potty training, for example, for our children. I also would like to acknowledge that we do have clinical practice guidelines that outline major components of the urinary bladder functions and dysfunctions and management practices for people with spinal cord injury. And these guidelines were developed by Paralyzed Veterans of America. And I hope that soon we will have Ukrainian version of these guidelines available for you. Let's talk briefly about innervation and function of urinary bladder. This hollow small organ has a very complex innervation. First of all, there is sympathoexcitatory innervation of the bladder coming from the lower thoracic segments where sympathetic preganglionic neurons localized, and through the hypogastric plexus, it is innervate dome and predominantly neck of the bladder. Parasympathetic neurons localized within the sacral area, specifically nucleus of onus, and it provides also tonic activation from parasympathetic nervous system to activate the bladder wall, to contract the bladder wall. And finally, somatic voluntary control portion of the bladder is external sphincter, and it's receive control from motor neurons within the also sacral region of the spinal cord. Parasympathetic nervous system, as I mentioned, responsible for a contraction of the detrusor muscle and emptying the bladder, very important function of the urinary bladder. Sympathetic nervous system responsible for the relaxation of the dome bladder and therefore storage of the urine in this hollow organ. Somatic nervous system, as I mentioned, this is a voluntary control of the bladder, and only external sphincter receives the voluntary control from somatic innervation, and it's obviously important control for the storage or emptying when we voluntarily ready to empty urinary bladder. When lesions to the central nervous system occurring, bladder function will differ dramatically. As you can imagine, we have patients with stroke, supraspinal cord injury, or supraspinal injury. We also have patients with a various level of spinal cord injury, above sacral area, within the sacral area, or even peripheral nerves could be injured. And therefore, function of the bladder will vary from the level of injury. Also, our management will vary depending on the level of injury. That's in general, we're subdividing function of the or dysfunctions following spinal cord injury. When bladder is overactive, typically we see it after stroke, after high level cervical spinal cord injury, or opposite, atonic, areflexic bladder, when a spinal cord injury occurred at the lumbosacral region or conus medullaris. The primary main recommendation at the present time that majority people with spinal cord injury should be considered for intermittent catheterization. That this is helps for long-term health of urinary bladder, prevent many dysfunctions, particularly hydronephrosis in people with spinal cord injury, and also prevent developing of such issues such as developing of calculus, urinary tract infections, and autonomic dysreflexia. Let's talk a little bit about neuromodulation in general. There are multiple various devices were developed during the last few decades. One of the most common presently approved method of neuromodulation for low urinary tract dysfunctions is sacral neuromodulation, where electrodes will be implanted to the sacral nerves at the sacrum. There is also data present on pudendal neuromodulation, percutaneous tibial nerve modulation that will also improve some bladder functions. But more modern technologies include epidural and transcutaneous spinal stimulation, which I would like to discuss with you today. First of all, difference between the epidural and transcutaneous stimulation is one is implantable, invasive method. Previously, epidural implants were approved for management of pain, and this is a well-used devices all around the world. And I know that in Ukraine, few patients I saw in the Rivne who already received these devices, but there is not yet device that was approved epidural transcutaneous for management of urinary tract dysfunctions, even though data are coming. That's why we will talk with you about the latest, hottest data about these devices with respect of improving bladder functions in people with spinal cord injury. This data is from my laboratory, Dr. Walter, urologist from Switzerland, worked in my laboratory, and what we demonstrated in person who received Medtronic implantable device. When we assessed him urodynamically, you see a red box below. his detrusal pressure, pelvic floor, EMG was dramatically changed with the epidural spinal cord stimulations that help with the storage and at a certain part of the day with emptying of his urinary bladder. Similar results were shown also with transcutaneous spinal cord stimulation. This is still right now in experimental process, but clinical trial is ongoing. This device was developed by Dr. Parag Gat and Dr. Reggie Edgerton in Los Angeles. And what you can see on his data with the use of transcutaneous stimulations, avoiding efficiency for part of diagram on A, as well as the bladder capacity improved dramatically in people with spinal cord injury when transcutaneous non-invasive stimulation was applied. This data coming from laboratory Dr. Hakima in Louisville, Kentucky. This is an epidural implantable device. And they can see that also bladder capacity with these devices in a few patients with spinal cord injury and detrusor pressure were dramatically changed, helping for the low urinary tract dysfunctions. Finally, I would like to conclude my short presentation with a very exciting news that just recently in January 2024, we received $2.5 million US dollars in a grant research funding from Department of Defense of US. And in collaboration with my colleagues from Ukraine, my co-principal investigator in Ukraine will be Dr. Andrei Burachik, and team of physiatrists, neurologists, and people with spinal cord injury will work with us together for next 3 years to looking how we can improve low urinary tract dysfunctions in people with spinal cord injury who are affected by this devastating condition in Ukraine. And our work will be conducted in Rivne. I'm looking forward to see you soon in July. All the best for the meeting. Thank you very much for your attention.
Yes, I do not know if he hears me, but thanks for this. And I think this research project really will be quite promising, and I'm curious to hear about the results. And
on this note,
no, but he has a second talk. Doesn't he have a second course? Okay. No, I don't want, No, I think there's one talk left by Mr. Krasikov, and I've seen it already, and it's also a very important topic, a topic which has gotten maybe a little bit too little attention this day. It's about sex.
Dear colleagues, dear friends, it is a great that I was able to join you, unfortunately, via Zoom and present some information regarding sexual health rehabilitation for individuals with spinal cord injury. First of all, I would like to thank you, all organizers of this very important meeting for Ukrainian rehabilitation efforts for people with spinal cord injury and all people involved, including World Health Organization, Klevan administration, Ministry of Health. Without further ado, I'm a physiatrist. I'm working in Vancouver Rehabilitation Center, GF Strong, and one of the biggest part of my clinical practice is helping men and women with spinal cord injury to pursue their desires to be sexually active and sexually happy. What I will try to address today, I will address two questions. We will discuss some major sexual dysfunctions that men and women with spinal cord injury present, and I also, in this short period of time, will try to present some possible rehabilitation strategies that we can offer at the present time to the men and women with spinal cord injury. First of all, I would like to emphasize that sexual function, rehabilitation, recovery from sexual function dysfunctions are identified by highest priority for recovery among people with spinal cord injury. As you can see here from the study by Dr. Anderson, sexual functions were identified as number 2 priority among people with tetraplegia, and number 1 priority amongst the people with paraplegia. That's why it's very important for us as a medical professionals to understand what we can do with these issues. I very briefly remind you that there are very important aspects of inhibitory and excitatory information that coming from the cortex, from the brain control that regulate our sexual functions. We describe them as psychogenic component of sexual arousal and sexual functions. However, after spinal cord injury, these influences from the brain are disrupted, and therefore, typically we see in a person with spinal cord injury predominantly only spinal cord related reflective sexual functions. For example, men with spinal cord injury still can have erections, particularly with cervical spinal cord injury, but it's typically reflex erections when we either catheterize person and so on. So what is a readiness of people with spinal cord injury after the injury to perceive information about spinal cord injury? From our personal research, we realize that in acute period of injury, people with spinal cord injury overwhelmed. They are so worried about recovery of motor functions that they sometimes push away sexual health clinicians. I'm not ready to talk about this. And we understand it. That's why we have to offer the information that there is some information available still during the acute period of rehabilitation. And when typically we see within 6 to 12 months after rehabilitation, person will come back to you and then they will be ready to receive this information. I have to remind you that this is a very delicate question, and when we're approaching men, women with spinal cord injury, we have to realize how challenging it is to talk about sexual health. How we can help people with spinal cord injury, where we will start. Most important, my message to my Ukrainian colleagues, we have to realize that use of multidisciplinary approach in a sexual health rehabilitation is the same approach as we're using in general for rehabilitation of people with spinal cord injury. I'm fortunate to work in a hospital where we have specialized sexual health rehabilitation clinic. There is a specialized team, including head physician, Dr. Stacy Elliott, and team of nurses who specialize in health rehabilitation with understanding of spinal cord injury and so on. That's why the use of multidisciplinary team is absolutely crucial. And this has to keep in mind by healthcare providers in Ukraine. If you're planning to open this kind of rehabilitation services, you have to organize a team. I also would like to approach and offer you some information from what is available in a general literature. SKY project is spinal cord injury rehabilitation evidence, is summary of all possible intervention and therapies that we can offer people with spinal cord injury with various areas. And one of the chapter is about sexual health rehabilitation. Let's start talk about, first of all, rehabilitation and women with spinal cord injury. One of the important aspects that we learned during the last 15, 20 years, the psychological barriers to engage in sexual activities after injury is very crucial for women with spinal cord injury. They very often feel that not attractive. They have low self-esteem. They have low sexual desire. That a lack of confidence to be sexually active is a very challenging aspect of rehabilitation of women with spinal cord injury. Physical problems in women with spinal cord injury. Also, impaired genital sensation, difficulty with positioning is a very commonly identified issues. Also remember, due to injury spinal cord, women with spinal cord injury also have bowel bladder function and as well decrease of vaginal lubrication that also prevent to be easily involved in sexual activities. What are the most common problems in women with spinal cord injury with respect to sexual health? First of all, sense of subjective arousal, orgasmic sensation. is a very, very challenging to achieve, and up to 50 to 80% of women with spinal cord injury experiencing some orgasm sensation, but it's totally different sensation in comparison with a non-injury. But this is still a very important issue. What about men with spinal cord injury? There are challenges with arousal. That's why 2/3 of men with spinal cord injury required some additional support in order to achieve erections, and therefore erectile dysfunctions are common in men with spinal cord injury, especially with low level of spinal cord injury, such as conus medullaris or cauda equina. Ejaculatory problems, another big issue with men with spinal cord injury, because don't forget that ejaculation in many men with spinal cord injury is associated with orgasmic sensation. And this is a quite common problem, is there is no ejaculation, there is no orgasm. Also be aware about very unusual situation with men with spinal cord injury. Even though ejaculation can occur, it's not anterograde, it's a retrograde. Semen will go back to the bladder, and therefore it is challenges with fertility. Men much more difficult experiencing orgasm following spinal cord injury. Only 40% of men reported that they could perceive some sensation of orgasmic sensation. What we typically offer at the present time to men or women with spinal cord injury with respect of improving of their sexual function. First of all, in order to improve, in order to improve their erectile dysfunctions, we're using phosphodiesterase inhibitor, 5 inhibitors, commonly known as Cialis, Viagra, and this is typically working quite well. Some men with low spinal cord injury require penile injections, such as progesterone injection, prostaglandin injections. But we're also using some non-pharmacological measures, such as vacuum devices, penile rings. There are also some data that intrauteral infusion of some medication could help with erectile dysfunctions. Excuse me. The last options of the management of erectile dysfunctions is the surgical intervention with penile prosthesis. We are much more limited with respect of help women with arousal, and therefore there are some non-pharmacological devices such as Eros device, which apply to the perineum, stimulate clitoral area, and looks like have some evidence to help with arousal. But also data present that sildenafil, again, phosphodiesterase inhibitors, could be helpful with these issues in women with spinal cord injury. Fertility is a big challenge in men. In women with spinal cord injury, fertility typically not affected by spinal cord injury, but in men, it's totally different issues. Men with incomplete spinal cord injury typically could ejaculate. Men with complete spinal cord injury have more difficulties with ejaculation, and therefore we typically require additional procedures, such as commonly used procedure vibrostimulation, penile vibrostimulation, which is quite helpful to achieve sperm. And then, depending on the sperm quality, we can offer various options to men become a father, including intravaginal or even IF in vitro fertilization. And in our practice, we know that up to 50% of men with spinal cord injury could achieve fatherhood with our support. I also would like to offer you some helpful advice from this book that was written by 2 of my occupational therapists in collaboration with Dr. Stacy Elliott. This book called Pleasure Able, and this has multiple variation of information with respect of sexual rehabilitation of people with spinal cord injury. In conclusion, I would like again emphasize that pleasure and sexual rehabilitation very important aspect our work with men and women with spinal cord injury. Mindfulness, psychological support is a very useful tool for sexual adjustment after the spinal cord injury. Males and females' fertility spans all aspects of the good, bad, and ugly, that we will have to be very persistent in order to offer help these people to become fathers or mothers after spinal cord injury. Education is a crucial aspect. Education of patients, but also education of partners, education of the families. And again, I would like to emphasize that access to specialized multidisciplinary sexual health rehabilitation team is crucial in this area. And I would like to finish with these two beautiful photos of my patients who will help to become mothers and fathers after the period when they become spinal cord injured individuals. Thank you very much for your attention. I will be happy to answer your questions, but you have to send me email. Thank you very much.
Yeah.
І я думаю, що це в нас
I think this is the final presentation for today, and I have the honor to present again Ruth Kirchner, who will be speaking about botulinum toxin treatment, and I know this topic is quite interesting for majority, and welcome.
Dear colleagues, and I hope Dear colleagues, let us now talk about botulinum toxin treatment for individuals with spinal cord injury. I don't even know if botulinum toxin A is available in the moment in Ukraine, but if not, it is something definitely worthwhile to pursue. Botulism and the then unnamed bacterium causing the disease were first described in 1822. The effect on nerve cells was already suspected, but the mechanism of action itself was not yet known. The first to introduce Botox into the bladder was Manfred Störer, by the way, who was the first who introduced me to neurourology and urged me to become a member of ISCOS. Botulinum toxin is currently approved for the following indications. In addition to its broad application in beauty medicine, it is used primarily in the neurological field to treat spasticity. I will now concentrate on the application in the bladder. In neurourology, the use of Botox to treat neurogenic urinary bladder overactivity with or without urinary incontinence will be the focus of my talk. For me, botulinum toxin is a true game changer for managing spinal cord injured patients with diffuse overactivity, which we cannot manage with antimuscarinics alone. Remember, to do intermittent catheterization, you need a stable, flaccid bladder. And if antimuscarinics don't do the work, you need in addition or alone botulinum toxin. If we look at the physiology of the bladder, we have heard that several times this morning, we can functionally distinguish between two phases. The storage phase, in which the tissues are relaxed, and the sphincter contraction are sympathetically induced via adrenergic receptors. And, of course, the voiding phase, in which a detrusor contraction occurs via muscarinic receptors. Botulinum toxin has also an effect on the afferent sensation, but this action is more complicated and still many points seem to be unclear. I do not want to talk a lot about the action of botulinum toxin. It is best described as a form of chemical denervation. Its main action is the inhibition of the presynaptic release of acetylcholine, and this leads to the blocking of neuromuscular stimulus transmission. Although retrograde axonal transport of the toxin has been described, retrograde transsynaptic transmission has never been described at the low doses we use therapeutically. This explains why a local application hardly ever has any central nervous side effects. In our guidelines, published last year, there was a consensus about use of botulinum toxin as a treatment in the bladder. It's a little bit more difficult in patients with detrusor sphincter dyssynergia and difficulties using intermittent catheterization. To treat those with botulinum toxin injections into the external sphincter. But it can be very helpful. You use much less doses, and usually it requires short-term repetition. In Germany, this is still an off-label use, and there are no clarification about the definition of this method. But it is helpful for some. Binding of botulinum toxin is irreversible, but the effects are reversible, probably due to micromorphological changes. The duration of the effect depends on the muscle type. Longer effects in the smooth muscle, like in the detrusor, than in striated muscle. In smooth muscles, the detrusor effect lasts about 6 to 9 months. The contraindications, according to specialist information, include the following points. There are no data, and that's why we are hesitant to do it, during pregnancy and breastfeeding, so this is normally not recommended. In the autoimmune diseases mentioned here with weakness of the striated muscles, there have been individual case description in which an exacerbation has occurred. In case of urinary tract infection, it is particularly important that the injection is not carried out during an acute infection. In our clinic, we use preoperative urine culture to rule out an acute infection and initiate antibiotic therapy appropriate to the test, which then be started at least 24 hours in advance and continue for 3 days. The use of anticoagulation must be considered individually by the surgeon, but is therefore only a relative contraindication. What is needed for the injection of botulinum toxin? Let me see. What is needed for botulinum toxin? We need an absorbent instrumental cover and sterile gloves. We also need a rigid or flexed cystoscope with an injection port, a cystoscopy needle, which is suitable for the cystoscope, an additional syringe with saline solution, and we normally do this procedure by local anesthesia. In some regional or general anesthesia is required, especially those with high lesions, and especially if we are afraid of autonomic dysreflexia. Here you see a picture, and there is a discussion about doing the injections only above the trigonum, but the newest data show that it is safe to include the trigonum and that the effect then lasts longer. And for botulinum toxin, different units are used than if you use other devices. So here you see how it is done. You can do it with a flexible or with a rigid stethoscope. Here you see how it's prepared. Urodynamic control can be done 3 to 4 weeks after injection when the full effect is expected. One should be aware of possible urinary tract infections, and the patient has to be instructed carefully, especially if voiding is replaced by intermittent catheterization. To understand, this is the best way to avoid kidney damage. One should always control whether catheterization is done correctly and the bladder is emptied. Re-injection if symptoms like incontinence occur in about 6 to 9 months, not earlier than 3 months. Oh, this is... I think the talk is a little... Some repetition. We translated, I wanted to make sure that the slides are in Ukrainian, but I see that my talk is a little bit shorter than what I translated. So if you use a Botox, we start with 200 units, and then we can increase up to 300 units, and we use 30 injection points. And we also use with other devices, like from Ipsen with Dysport, we need more units, 500 to 800 units, but again in 30 injection points. Thanks you for your attention, and thanks again for all who made this possible. I look forward if you have any questions.
Якісь питання за аудиторією до пан Рут, до...
Any questions to Ruth from our room? So, dear participants, with all my heart, thank you for your time, staying online, for coming here and being interested by this topic, and let's hope that we will make the lives of our patients a bit better, a bit more difficult, and we will have less complications. We'll have more time for holidays. When once again, lots of things to those who have embroidered shirts, and once again, certificates will be sent by the electronic post. This is the requirement of the Ministry of Health, but they will be testing with 10 points sent to your mails, and certificate in some 1 or 2 weeks, depending on the decision on the Ministry of Health. About every participant, it will be sent 2 emails. If somebody didn't get the certificate at least 2 weeks later, contact us about your proposals, discussions, and offers. Thank you.